medical environment and nursing in places far from the ICU in resource-rich countries, and she's also engaged in education and with local staff and local environments. So we're very, very pleased that she's come to us to share her expertise. Thank you so much.
Good afternoon, everyone, and thank you for joining my presentation today. I am Hiroko Sekiyama, and I am a registered nurse in 18 years, 10 of which have been ICU. Several studies have provided evidence of the benefits of early mobilization of critically ill patients, including improved patient outcomes and reduced complications. It has also been reported that nurses take the lead in rehabilitation, contributing to better communication with physiotherapists in the ICU, sedation, pain control, and sleep quality. As a result, duration of ventilator placement, ICU stay, and hospital stay can be reduced. It is also said that placing an early mobilization algorithm and providing evidence-based training on mobilization improves nurses' knowledge and behavior of patient mobility. As a result, patient immobility will decrease, positively impacting outcomes, so it is possible and significant for bedside nurses to take the lead in encourage mobilization in the ICU. However, there are various barriers to starting and establishing early rehabilitation in the ICU. I have experience in a hospital with the rehabilitation culture in the ICUs and hospitals that do not yet have one. During this time, I considered what I could do as a nurse to establish and promote a culture of rehabilitation in this ICU every day. Based on that experience, I would like to talk about 4 things that I think are important in the role of the nurse in promoting ICU rehabilitation. First and foremost, it is important to understand the culture of your ICU. It's the reason there is no culture of rehabilitation because staff do not do it, or because they simply don't want to. Or is it because they want to do it, but can't or don't feel we can? Even though the situation is ultimately the same, the response will differ in these 2 cases. The latter is the most common reason for not having a rehabilitation culture. That was the case in my ICU too. In that case, what's needed is to show understanding of the staff distress, suggest a way to respond, and support what the staff does. This is a culture at my ICU that we wanted to have, but we couldn't. The nurses did not have a concrete image of doing rehabilitation in ICU. And even if we wanted to do, they thought they would be too busy to do it without more staff. Doctor and rehabilitation staff wanted the nurses to be more actively involved, but were not taking concrete action. One reason for this was that they were hesitant to talk to the nurses because they thought they were busy and did not seem to listen to them, and looked so scary. Do you have anything in common with your ICU? So the second point, it's better to start with small things you can do yourself. Building the rehabilitation team and creating protocol takes time. So I started with small things I could do at the bedside. For example, ask the patient to lie their arm when placing the thermometer in the armpit or wrapping blood pressure monitor around the arm. And then try doing ROM for each upper rib about 10 times. Or encourage patients to unbutton and fasten button when changing clothes. These are some mobilization while care methods recommended by the Japan Society for Early Mobilization. This can also be implemented for patients on ventilator or CRT. During the day, patients are often positioned in the sitting position in the bed as part of mobilization. However, once sitting becomes a goal, patients often immediately request to lie down. Therefore, I establish a goal and objective with the patient before sitting down. Various activities are available, such as watching a video, reading a book or newspaper, or writing a letter to family. Folding laundry is also a good activity. Instructing the patient to extend their arm and push out the chest, but the alternative to ROM, and also serve as respiratory care. And through this initiative, I made a conscious effort to show the ICU staff that I was strongly interested in rehabilitation and early mobilization, because I wanted the ICU staff to have an impression that rehabilitation equals you. So I actively tried to discuss pain and sedation control and rehabilitation detail with doctor and rehabilitation staff. If this impression can be created, doctors and rehabilitation staff will know who to contact if they needed to consult or ask a nurse about the rehabilitation. This will facilitate various discussion. Collaborative rehabilitation will also be possible. It will be easier to cover staff shortage in the ICU, to involve family members in rehabilitation, and expand the rehabilitation program while ensuring their safety. On this impression that the rehabilitation equals you is established, nurses will come to me for advice on rehabilitation. Staff who actively ask are often very interested in this. First, get those nurses involved. While caring for them together, I try to teach them how to do mobilization while caring. We also collaborated with the rehabilitation staff to make rehabilitation menu that could use nurses on weekends. As the number of the nurses for whom rehabilitation equals you increases in the ICU, it becomes easier to create mobilization teams. On the other hand, some nurses are less interested in rehabilitation, and some of them have a strongly interested in other areas, such as hemodynamic monitoring and respiratory management. I ask those staff members to provide consultation and guidance regarding general management and safety during rehabilitation. Rather than simply encourage staff to carry out rehabilitation, it would be more acceptable to understand each member's characteristics and have them use their strengths to intervene. Gradually, it becomes established to wake patients with light sedation during the day and to think about how patients could be early mobilization after admission to the ICU as soon as possible. We could collaborate more naturally with doctor, rehabilitation staff, and other medical staff in the ICU. This made nurses feel more secure in the rehabilitation and getting out of bed, and they became more proactive rehabilitation. As they gain experience, they understood the method, precaution, and procedure for getting out of bed. The big fear of moving ICU patients out of bed faded, allowing nurses to be more proactive. This has created a virtuous cycle for establishing a culture of early mobilization and rehabilitation in our ICU. Not providing rehabilitation will seem unnatural once the culture of early mobilization and rehabilitation is established. In the ICU, I found it rewarding to care for patients as a team, and now I am a member of the International Medical Volunteer Organization Japan Heart. After working at a remote hospital in Japan, I have worked as a volunteer nurse at the Japan Heart Children's Medical Center, JHCMC, in Cambodia since last November. I would like to talk about 3 points that I feel are important when working with early mobilization in the remote and developing countries. At first glance, it may seem unrelated to the ICU, but I feel that it is a perspective we should also be aware of in the acute care setting. First, about informing and educating medical staff. JHCMC has adult ward phase 1 and pediatric ward phase 2. Outpatient visit and surgery temporarily decreased due to the coronavirus pandemic, but have now returned to pre-COVID levels. Over 2,000 outpatient visits and more than 100 surgeries are performed each month on both pediatric and adult patients. Surgery is various specialties are being carried out. 2 ICU beds have been reserved for phase 2, but other patients, including adults, must be managed in general ward. Just as I was preparing this slide, we had a patient who needed intensive care management after surgery. There is no central piping in the hospital. Oxygen for the ventilator is supplied from oxygen tank, and there are no motorized bed and air mats, and phase 1 is just only a large room. In this situation, I was thinking daily about how much of my experience I could give back here in the care of this patient. In Cambodia, the family is primarily responsible for helping with daily life during hospitalization, which is a huge difference from Japan. For this reason, I felt a difference in the perception of nursing between the Japanese and the local nurses, so I conducted some brief interview. It turned out that senior nurses have fewer opportunity to learn about early mobilization and rehabilitation during their educational curriculum, and even fewer staff recognize that nurses should practice these skills even if they have a knowledge. The difference between dementia and delirium was also unclear, and there were a certain number of nurses who had never heard of the word delirium. Additionally, while JHCMC currently does not have a rehabilitation staff, very few staff have experience working with rehabilitation staff, even though training or other means. It is not easy for staff with such background to understand and practice early mobilization. Therefore, an early mobilization team was formed at the end of last year. Japanese and local nurses are working together to promote early mobilization, such as holding study sessions on the need for it and complications associated with bed rest. Awareness of early mobilization is gradually spreading among local staff. Next is education for patient and family. Assistance with daily living during hospitalization is primarily the responsibility of the family, who remain at the bedside at all times during hospitalization. It is not common for hospital to provide a meal during hospitalization in Cambodia. The many family gradually assist with eating, excursion, movement, and hygiene, including preparing a meal after surgery. When patient requests rest due to the pain or other reason, family may not encourage them to move any further. It is essential to actively collect information, such as what kind of intervention from family are providing, and to involve family gaining their understanding and cooperation with early mobilization and rehabilitation. Finally, it is important to consider intervention that support the strengths of each ward or facility. I am currently working in the adult ward, but I have only seen one patient who developed delirium, a man in his 90s. There are differences in the patient population in Japan, where the birth rate is declining and the population is aging, and in Cambodia, where the average age is just 27. However, I feel that having a family present at all times helps to reduce the incidence of delirium. There is very strong family bond present. Many families come to the hospital together when the family becomes ill. A family who cannot be attended to in the hospital stay on the ground and watch over the patients and the attending family through the window. In Japan, various rules have existed regarding visitors' time, number, blood relationship, and the items that could be brought to the ICU before COVID-19. How can we prevent PICS and PICS-F? The rule of the hospital, especially in the ICU, requires various restrictions. However, we must consider how much freedom we can give them. Providing an environment where patients can connect with their family and loved ones, even through the window, and feel like they are in their daily lives while hospitalization gives patients and their family a sense of security. And the take-home message: first, try to understand the ICU culture while also pay attention to the certain nursing culture, which should continue and be encouraged. The staff can notice and be happy about even small positive patient changes. It is one of the important culture. And then, when you start small. And when you get staff involved, understand and use each staff member's strengths. Nurses are always at the bedside, and we often have many opportunities to interact with other professionals and play the role of liaison and coordination. I think these are great strengths of nurses, and there is a lot we can do. Finally, share the knowledge and the experience you have gained with those around you. I feel this most strongly in my past experience and certain activity. Patients cannot choose an ICU that is doing active rehabilitation. In addition, even if the ICU is a proactive rehabilitation, continuing this in the world can be difficult. Even in Japan, there is a severe nursing shortage in remote areas, so early mobilization is considered special, not daily task. I feel my experience in the ICU has been useful in helping other practice early mobilization by incorporating both the patient's desire to get up and the nurse's desire to help the patient up. Just as the PICS care needed to continue even after patient leave the ICU, I think once the culture and environment with the ICU has been improved, it is essential to intervene in the world environment beyond that. Thank you.
And we'll do the questions after the third presentation.
Okay, we will move on to second speaker. I introduced Dr. Son. Dr. Panti Son is from Tam An Hospital. This hospital. She is head of the intensive care and clinical toxicology department here. She graduated from the University of Medicine and Pharmacy at Ho Chi Minh City and graduate internship from the same hospital. And during 1993 to 2021, she was a doctor and the head of the intensive care department at Cho Ray Hospital, Ho Chi Minh City. Today's topic is the role of high flow oxygenation in early mobilization. Please, Dr. Son, please.
Thank you.
So I'm working more than 30 years in ICU, and luckily, I have worked in GRA for 30 years, and I moved to Tâm Anh to work. And the leader of the two hospitals see the importance of rehabilitation to improve the recovery of patient. So there are lots of the rehab staff available in the ICU to support the doctor. So here we have more staff to work on rehabilitation, specifically for the ICU. So they know exactly what's going on with the patient. In the morning, when you see the new patient, they will ask when we should start to do the rehab and mobilization, and the doctor will tell and discuss with the rehab staff the patient can sit or stand up. So the discussion between the doctor and the rehab staff come better between. So what we want to improve is that in the ICU we feel insecure if we start early mobilizations for the patient. So we need to have a discussion with the rehab team. And the doctor too busy, and they just leave all the rehab work for the nurse staff and the rehab team. And when the rehab team come to see the patient, they say a lot of cannula and lines, so they feel difficult to approach the patient and don't know how to support the patient. So after this conference, so I wish we have a good collaboration between the doctors and the rehab team to understand and stand by the rehab teams to secure the patients and to show the early mobilization is good for the patient recovery. Today we talk about the high flow nasal cannula therapy. So to me, the small things can make change a lot. This small machine is an evolution in medicine. The patient depending on the mechanical ventilation for a long time, but with this machine, the patient has shorter time in the ICU. So after the patient extubate, we have this machine to support the patient, so they feel relaxed, they feel more comfortable, so they can start early mobilization. For the contents, I'm talking about the high flow nasal cannula, because in the world, people has used this machine for a long time to support the patient. So I will focus on the setting, the mechanisms, how SSMC can support the patient with respiratory failures, indications, setting, and not during the physical therapy. From yesterday and today, we see ICU acquired witness happen in 40% of the patient survive from ICU. ICU-acquired weakness result in many complications, difficult to win the ventilator, failures of extubation. The patient depend on the ventilator for a long time, increase the financial, the increased mortality. In the ICU, also mortality after ICU. Also, ICU-acquired weakness affect to the quality of life the patient after discharge from the hospital. Because the patient depends on a wheelchair, there are multiple factors results in the ICU-acquired weakness, especially the steroids, muscle relaxant, and one of the important reason of ICU-acquired weakness is not early mobilization in ICU. So ITSMC is support and facilitates for the patient for early mobilization. How the machine works? It's small and it's simple. The patient tolerates well. Not only doctor, but the nurse or the physiotherapist can use the machine. It's simple. It's take the oxygen and mix with the oxy from the system and get through the humidifier and through the circuits and get to the patient. The flow can go up to 60 liters per minute. We can adjust the FiO2 depending on the needs of the patient from 21 to 100%. The flow from 60 to 100 liters per minute. The humidifier can be achieved 100%. It's very simple with 3 knots to adjust the setting. We can adjust the temperature 37%, adjust the flow, so when the physiotherapist of the patient increase the effort, we can increase the FiO2. The doctor in ICU see this kind of machine is too easy to use. So it gets more common to use in the ICU compared to the conventional mechanical ventilation. Those SFNC is a valuable setting in all the conventional mechanical ventilator. So after extubation, we can use the setting of SFNC on the mechanical ventilator, but it's hard to move. SFNC is a small machine. The patient can move with the ventilator and can feel comfortable. What mechanism that make the SFNC can improve the respiratory failure status, so improve the work of breathing. So this machine increase the peak inspiratory flow. In normal status, the patient can have 35 liters per minute, and then the patient have effort. The flow can increase to 45 liters per minute. So if the patient try to work hard to breathe, they feel exhausted. Until they collapse, and we have to intubate them. If we have the machine to provide the high flow, to achieve the highest flow that the patient required, from 45 to even 100 liters per minute, so we can help the patient reduce the work of breathing. The second mechanism is this machine can help to wash out CO2. So we understand about the dead space. Firstly, this is the area where it contains CO2. With the high flow of air, 40-60 liters per minute, it will wash out CO2, so reduce the dead space, and then reduce the work of breathing. The third mechanism is provide the high concentration of oxygen. So normally we have the low flow system to support the patient to provide oxygen like nasal from simple face mask or non-rebreather mask. For the non-rebreather mask can provide 100% oxygen. Theoretically, however, for the patient with respiratory failures, FiO2 in this case would not be 100%. With high flow system, with the high flow, so the oxygen can be 100% because the air will come directly to the trachea. And another mechanisms that SFNC can improve the respiratory failures, it improve the oxygenation. The airway pressure improve during the high airway, high flow. It prevents the atelectasis of the lung and improve the oxygenation. The mean pressure airway improve depend on the flow. Every 10 liters per minute increase, it will increase 1 centimeter quarter. So with the flow of 60, we increase the PIP to 5 centimeter quarter. It's also important to notice the humidifier 100% when we use SFNC. The humidity improved to 100% when we increase the temperature, it's 37 degrees Celsius. So the air from the room is dry. The humidity is just 40%. But when we increase the temperature of the water of the humidifier system, so the air will get the humidity of 100%. That improve the function of the mucus and the patient tolerate better with the machine. Before SFMC, we use the non-invasive support with the face mask. For the patient with respiratory failures, the patient feel discomfort. And the face mask strongly puts a pressure on the face. And the face feel very discomfortable. Before SFNC, the patient have cannula, provide oxygen, and not too tight to the face. The patient feel more comfortable compared to a face mask. The cannula does not block totally the air. So as you can see, partly open air. There's space for air get in and out. The patient feel easy to tolerate the machine. Indications for SFNC include several indications below, and we see on the screen the clinical practice guideline AARC. Indications include the patient failure with the mask, there no indication for the patient with the prolonged accumulation CO2. But for these guidelines, we have indication for COPD patient. Until 2021, there's not many evidence about benefits of SFNC for the COPD patient. However, now we have multiple evidence of efficacy for COPD compared to CPAP. After extubation, efficiency give more benefits, are more successful compared to CPAP in terms of re-intubation. SFNC indicates for the patient post-extubation. We can extubate earlier than before to prevent the And lastly, we use for immunocompromised. The patient with immunocompromised easily get the hospital-acquired infection and die because of the infection. Long time ago, we also use different type of non-invasive support for the patient who are immunocompromised. And with efficacy, the patient tolerate well. I'm glad that many physiotherapists use this kind of machine to support the patient with chronic diseases. This data study analyzed the benefits of efficiency to support the patient with chronic diseases like COPD or cancer. So it improves the systemic hemodynamic, improves the tissue hypoxia, and muscle reconditioning of these patients. I want to focus on the setting when the physiotherapist use this machine for the patient and know how to adjust the setting. It's not complicated. We start with the low flow of 20 to 35 liters per minute. Some of the patients feel very sensitive with the high flow, so we start with the low flow and then increase gradually to high flow level. And then the patient feel tolerate well. Then we stop until we see the patient reduce the work of breathing. We look the SpO2 and see the number around 95% or 90% on if the patient have chronic disease. And the temperature we set 37 centigrade degree to achieve the humidifies 100%. We should have some notice when we do physiotherapy about the transmission, especially air transmission. So if the patient has influenza, it's easy to transmit to the healthcare staff. So for the medical staff, we should be careful about the airborne transmission. The droplet nuclei less than 5 micrometers. If the patient using SSMC and during the COVID-19 or with the influenza, so we should be careful about the transmission from patient to the medical staff by wearing a surgical mask. Or we can use the filter to try to reduce the transmission. So the physiotherapist or rehab team should wear the standard equipment to protect prevent the transmission from the patient. We should notice the patient should close the mouth. If we talk to the patient and the patient open the mouth continuously and we cannot keep the good pressure. And in practice, some patients can't open the mouth frequently, so we use the mask to cover the nose and mouth. One more notice is that the patient try to breathe more, and so when we do the physiotherapy, we should increase the FiO2. It's very easy. We just adjust the oxygen bottom, so the oxygen can increase and the patient will not be hypoxemia. When the patient do exercise, so they increase the walk breathing, increase the respiratory rate. So the physiotherapy should increase the flow. The nurse or the physiotherapy can do this. Increase the flow from 40 to 50 liters per minute, for example. And after finish the physiotherapy exercise, so we can decrease to the level, the current level. The limitation of each device should be recognized. So SFNC, when we know the patient failed with this machine, it should move to another intervention. So we use ROX index. This is FiO2, SpO2 divide FiO2 divide and respiratory rate. It's dropped below 3.8. So he should be intubated. Should be intubated. If SpO2 around 92% and the respiratory rate is around 35, and the patient already with very high flow, up to 50-60 liters per minute, but the patient's still hypoxemia, so we should not do physiotherapy, and the patient have indication for intubation. The patient will evaluate for ROX score every 2 hours. And if below 3.8, the patient should be intubated. So this is the end of my presentation. Thank you for your listening.
We have a Q&A session after next speaker's presentation.
Thank you so much. So I'm very pleased to introduce a friend and colleague, best known as Cats, kind of like Madonna, just one word. Hajime Katsukawa is a physical therapist and has a PhD and is chair of the famous Japanese Society of Early Mobilization, which was established in 2005 as a nonprofit academic society. There are more than 4,500 registered members in the Japanese Society of Early Mobilization. CATS developed an educational system and a license about early mobilization with more than 10,000 people per year participating in the JSEM education. He also presents educational lectures about early mobilization for more than 400 hours per year. He's conducted the annual conference of JSEM for 10 years and his specialized field, of course, is early mobilization for critically ill patients. He's published many articles, including a clinical textbook read by more than 100,000 people. He's a committee member of our Asia Pacific ICU Early Mobilization Conference, and he acted as the first host of this conference in Tokyo in 2015. So thank you so much for speaking, Katz.
Thank you for introducing me. I also appreciate Min and Luis and all Vietnam delegates holding a wonderful conference. Thank you. So I start my presentation. When hearing about critical ill patient in ICU, many people may image sepsis and ARDS. As you know, sepsis is a condition where bacteria invade the bloodstream and resulting in hypertension known as septic shock due to increased vascular permeability. On the other hand, ARDS is a condition where fluid leaks into the lungs due to increased vascular permeability caused by invasion, resulting in poor oxygenation. Sepsis and ARDS have a serious impact on breathing and circulation, making it difficult to determine if mobilized or not. When nurses or rehabilitation staff go to the patient's bedside, they might hesitate to mobilize them due to the presence of many lines and tubes. What measure is effective for early safety mobilization? As one of the solutions, I suggest using a checklist. When the staff mobilize the patient, sometimes they don't get positive results. It is necessary to assess the patient's overall condition and determine whether they are in a state suitable for mobilization. This checklist can serve as a guide for deciding the timing of mobilization. I have created a checklist focused on respiratory and circulation. I will start a presentation for the items related to circulation. These circulation-related items are based on safety standards obtained from a Delphi study that I attended as one of panelists. First, in case of using 2 or more bus-active drugs. These drugs are used according to the patient's circulatory condition, but when 2 or more are administered, the risk is higher than only one drug is used. When 2 or more bus-active drugs are administered, mobilization staff should discuss with physician or senior staff if that patient can mobilize or not. The second checklist is the dosage of each drug. If dosage is moderate or higher, mobilization should not be decided by a single staff alone. All team members should discuss if patients can be mobilized or not. A moderate or higher dose is defined as 0.2 or more for norepinephrine and adrenaline, and 10 or more for dopamine. Moreover, even if these bus-active drugs are administered, aggressive mobilization should be avoided in those cases. Case 1 is blood pressure is not reached to target. Case 2 is additional drug administration is required because blood pressure did not rise. Those cases indicate that circulation is still unstable. Aggressive mobilization should be avoided. Additionally, when considering blood pressure maintenance in sepsis patients, we should consider the function of vascular endothelial cells. Vascular endothelial cells significantly contribute to maintaining intravascular fluid. However, when sepsis causes systematic inflammation, the function of vascular and cellular cells deteriorates. Fluid leaks into the intracellular space, and blood pressure drops. In this situation, when you mobilize patient, orthostatic hypotension will be occurred easily. It have come to calm down inflammation by sepsis. The function of vascular and cellular cells recovers, and blood pressure was maintained. So how should we evaluate the function of vascular and cellular cells? Let me present a case. Please imagine a patient with a mean blood pressure of 70 who is receiving norepinephrine at 0.2. Physician judges that patient's blood pressure going stable and the dosage is reduced to 0.18. As a result, mean blood pressure drops to 60. What should we do as the next step in this situation? You have two options. Revert the dosage back to 0.2 immediately, or wait a little longer at 0.18. Which would you choose? Our team's recommendation is waiting for just 30 minutes. Immediately reverting to 0.2 may restore the blood pressure and give you peace of mind, but we don't evaluate the recovery of vascular and cellular function. What might happen if you wait for 30 minutes at 0.18? From my experience, in many cases, the blood pressure gradually returns to 70 during 30 times. This change suggests recovery of vascular and cellular function. If blood pressure does not recover, it may indicate that cellular function has not fully recovered, and norepinephrine dosage should be increased back to 0.2. When you change the dosage and norepinephrine, evaluating the result of blood pressure and short-term changes may be one idea for assessing vascular and cellular function and thinking mobilization plan. Additionally, it's important to assess patients' hands and feet, warm or cold. In the early phase of septic shock, patients' extremity become warm because of vasodilation. However, inflammation is progressing and vascular and cellular function deteriorates. Patients' extremity become cold because the blood vessels lose flexibility and constrict. Extremity cold sign indicates the progression of circulatory failure. So when warm extremities become cold, aggressive mobilization should be avoided. I presented regarding 3 checkpoints. If you meet these conditions, it is essential to consult with physicians or senior staff and decide to mobilize or not. If only one vasodilator is being administered, blood pressure is stable, and no additional drugs are required, then aggressive mobilization, for example, sitting on the edge of bed, standing, can be considered. So you may have a question, for example, is mobilization safe for ARDS patient and septic patient? What position is cautious? To answer these questions, I conducted multi-center trials. This study included patients on mechanical ventilation with endotracheal tube, including receiving vasopressor in 9 sites. The results showed no life-threatening safety events. This indicates early mobilization for critical ill patients is safe. However, several potential safety events, such as desaturation and blood pressure drops, occurred in 6.6% of patients. Those events don't need additional medication or care, but we want to prevent those safety events as much as possible. So I evaluated the number of safety events by type of position, sitting, standing, and walking. As a result, potential safety event occurred most frequently standing. Reason of this, fluid shift to lower body will be affected from sitting to standing position. Paying attention to respiratory and circulatory changes will be needed when you carry out standing. So, how often safety events occur by position? According to my research, when performing a sitting edge of bed, these events occurred once in every 40 times. When performing standing safety events occurred once in every 5 times. Again, this study focused on patients on mechanical ventilation with endotracheal tube. The incidence of adverse events might be lower in patients with tracheostomies or only receiving oxygen therapy. I think those results, when we consider mobilization in most critical patients, special attention should be given to standing. So, what support strategies can be considered to achieve standing successfully? First strategy is increasing those dose of vasopressors. Additional administration aimed at circulatory stability has been completed, but this decision is based on the supine position. We should think separately supine and standing. If hypotension is expected when stand up, we consider additional vasopressor support. It would be helpful for successful standing. Second strategy is adjusting the PEEP setting on mechanical ventilator. As you know, PEEP reduces venous return to left atrial by positive pressure. In case of patient with low blood pressure, this reduction of venous return can cause orthostatic hypotension. Therefore, in patients whose respiratory and circulatory status is improving, check for excessive PEEP values. If excess PEEP can be removed, orthostatic hypotension may be prevented when standing. A third strategy is using elastic bands for lower extremities. Using elastic bandages can reduce the blood flow shift to lower extremities during position changes to standing. This helps maintain blood flow to the upper body, potentially stabilizing blood pressure during standing. Please consider these strategies for safety mobilization. Next is criteria related respiratory parameters. When you meet ARDS patient, what criteria do you use to decide whether aggressive mobilization or prone? That hint is in the ESICM guidelines. According to that guideline, prone positioning is recommended for patients with a PF ratio of 150 or less and a PEEP of 5 or more. Prone position for severe ARDS patient has evidence-reduced mortality. Prone positioning is effective to ventilate the whole lung and reduce the burden to the part of lung. Those photos are lung impedance tomography device, which allows visualization of which part of the lung is ventilated with each breath. The blue area is getting air entry, like a CT scan. Photo shows the lung sliced in a circle, with a number 3 and 4 being on the backside. In the supine position, air entry is concentrated in the central part of the lungs. In contrast, in the prone position, more air entry occurs in the posterior lung regions, indicating that the whole lung is ventilated. Prone position doesn't take stress a specific part of lung. It is helpful for preventing ventilator-induced lung injury. If patient's PF ratio is below 150, prone position should be considered. In case of doing prone position, we must be careful using neuromuscular blockers. In most severe ARDS case, sometimes neuromuscular blockers are used to suppress spontaneous breathing. Strong spontaneous breathing in most severe ARDS patients can damage their alveoli. That causes patients self-inflicted lung injury. The video shows the pattern of air entry into severe ARDS lung with spontaneous breathing. Air entry is uneven, resulting in a phenomenon known as Pendeluft. However, the administration of neuromuscular blocker can lead to prolonged bed rest using of deep sedative drugs, increasing the risk of ICU and mortality. Therefore, using neuromuscular blockers should be limited. Prone position will be recommended in severe ARDS patients, but we should pay most considerable attention for using neuromuscular blockers. So, when we could start aggressive mobilization, perform prone positioning, or perform aggressive mobilization, we need to carefully determine the timing to choose the appropriate treatment. For patients who develop ARDS and are managed in the ICU, prone positioning should be considered if their PF ratio is below 150. If patient's PF ratio above 150, mobilization should be considered. The critical point is not to miss the earliest opportunity to start aggressive mobilization. So having criteria of a PF ratio 150 means that everything will proceed smoothly. It is a variable indicator, but we should consider the patient response and patient assessment when attempting mobilization. If during attempting aggressive mobilization, for example, sitting edge of bed and standing, those symptoms are useful. Number one, respiratory rate 30 and more. Number two, saturation less than 90%. Number three, the need to increase ventilatory support pressures. It can be judged that aggressive mobilization is still too early. In most severe disease like ARDS, early mobilization should be carefully considered balance of the risk and benefits. If respiratory symptoms worsen, indicating that the risk outweighs the benefit, aggressive mobilization could not be carried out. However, if such symptoms are not observed, aggressive mobilization should be attempted. As discussed in previous presentations, if aggressive mobilization can be safely performed, it would be effective for functional recovery and improvement of ADL. For safety mobilization, please do careful assessment in addition to that checklist. I presented regarding the checkpoint for sepsis and ARDS patients. I'm happy many clinicians would use that checkpoint on the bedside. So lastly, I would like to inform regarding the next Asian Pacific Conference. Next place is Tokyo, Japan. Date is June 1st after World PT Conference. Japan has many attractive sightseeing points and delicious food. Please save the date and come to Japan together. Thank you for your attention.
Thank you, all of the three speakers in this session. We are now open the comments and question from the floor. Anybody have a question?
Okay, can you hear me? Okay. Okay. So for Dr. Sun, in your presentation, it looked like it was fairly heavy on the respiratory therapist role in the rehabilitation process. You were dealing with a lot of the oxygen modifications.
When I draft this presentation, I only think this machine is only applied for those working in emergency department or intensive care. But in current situation, this machine has become a tool for physiotherapists to rehabilitate the pulmonary function for COPD patient. So I modify my presentation a bit. I think that in the future, the PT will utilize this machine for their practice. In my opinion, this machine is very simple and the operation is very straightforward. So for the PT come to the patient on SFNC, as for in my department, at least there is around 10 patients on SFNC in my department. If my nurses are not there, the PT staff can titrate the oxygen. It's very simple. As long as they can observe the increase of FiO2 on the machine. So when we exercise the patient, we will titrate the flow to better suit the need for patient respiratory demand. Right now, the current model of this machine is a little bit difficult to increase the flow, but with adequate training, the PT staff can do this. So when we put the patient on exertional exercise, so it is not very difficult. So in my opinion, the PT staff can learn and operate this machine well. Because I have to admit that sometimes we are short on staff, so the titration of this, the flow and FiO2 on this machine is simple. It is not as difficult as other machines in ICU. So I think this So Dr. Sun repeat on the shortage of staff. So the PT staff can easily titrate on their own to better suit the patient's need. Yeah, thank you.
The second question was for Katz on the protocol. And I kind of alluded to this earlier, and it just kind of goes back to artificially holding blood pressures down. So, you know, we're trying to deliver oxygen, and this kind of all interrelates. If you're artificially using blood pressure medications to change, now you're changing position, increasing activity, and if you're still artificially holding that down, how does the interplay of modifying the oxygen level, blood pressure, in terms of safely mobilizing that patient into walking if, now I'm not in the ICU, so I don't know how heavily these patients are being medicated, but from some of the presentations, it sounds like some ICUs are fairly heavily medicating these patients. So how do you take into account blood pressure medications safely while you're mobilizing the patients. Because your baseline, the reason I'm saying that is because your baseline blood pressure seemed awfully low. I mean, you're looking at a 70 mg level. I mean, and you know they've age modified, because especially since we're dealing with an older population, typically, you know, they're age modifying blood pressure, normal blood pressure levels. That just seems like a fairly low level to begin with. So should we not be raising the target blood pressure?
Thank you for question. That case is most severe case in sepsis. Very low limitation I showed. Many cases upper mean blood pressure is above 70 or 71, 75. It's safe for mobilization. Please consider the low level. This is the most low level mobilization. But this level of mobilization is, I think, trial. And nobody knows if you can mobilize safe or not. One recommendation is please try and please observe the changing blood pressure. To drop blood pressure is revert the superimposition immediately, and if you need some medication. But many cases maintain blood pressure. Looks like very critical patient and not mobilizes like C, but try, and if you try, many cases okay for upright position keeping. Okay.
To add about this vasoactive drugs, actually in 2020 we did a literature review, and it was published in Journal of Acute Care Physical Therapy, a literature review on use of vasoactive drugs and early mobilization. And we found that the use of vasoactive drugs alone is not a criteria for not to mobilize. The holistic clinical evaluation helps. And the dosage up to moderate, that is 0.2, it's okay, it's safe. But still, we have to follow the slow progressive mobilization methods to see how the patient reacts. Another point, as you asked, other medications and other drugs, and it's all depends upon the clinical picture of the patients. For example, if there is any high requirement of high oxygen, that depends upon the lung injury that caused the disease. So it's not purely depending upon the drug or one drug or one clinical picture. So that's what we are. And when we reviewed the literature, we couldn't find a lot of mobilization reporting with a higher dose of vasopressors. And the incidence of adverse events with mobilization patients with inotropes, it's very less. It's very less. But also the occurrence or incidence of mobilization is also very less. And in my experience, we have mobilized the patients up to 0.4, that is higher than the moderate, 0.4 microgram per kg per minute of noradrenaline. And that patient stood up and there was no any issues. Thank you.
One more. Message to you and regarding question high flow oxygen therapy during mobilization. And in Japan, many staff mobilize patients with high flow therapy. Perhaps you educate the how to using machine. Perhaps PTO, and nurses can easily understand. And only one point is please educate a point. Important point is supply water. This is water. This high flow therapy is moisture gas, moisture oxygen for smooth airway, and during walking, empty the water and alarm is turned on. Please supply the water. Please educate. Okay.
Yes, please.
Good afternoon. It's a question for Professor Katz. If your patient would not meet the checklist or would be unstable for mobilization, when do you reevaluate the patient to resume mobilization? When do you reevaluate the patient again to check if the patient will be stable already? And if the patient at that point meets it, do you resume the patient in the same level of activity, or do you step down your activity before going forward? Thank you.
Okay, I understand. Thank you. Okay. If patient not tolerate high level mobilization, I will step down. Step down level. I will implement, and I will check the why not why they cannot the for example standing. I will check the laboratory and hypotension or hypervolume, and I will check many data and discuss with physician. I think the chance of cause of not mobilization find. I find and I will find the cause of not mobilized patient and will discuss physicians. If the cause of not mobilized you find, some doctor additional medication, some of PT elastic bandage using, and some of therapists and nurses take deep breathing and additional care and medication addition and try to same level. Okay.
Thank you.
And if, for example, the patient, to make sure your question's directly answered, if you saw the patient in the morning and they're too hypotensive, if there's a therapist embedded in the unit, usually they'll just come by later on in the afternoon. You know, that's the advantage. If there's the ability to have a PT there, they can just swing by later. If that doesn't happen, then certainly the next day would be appropriate. We always teach that ICU patients are so dynamic. Just because something went bad yesterday doesn't mean you should not reassess again today or later.
Thank you.
Okay, we have 3 or 4 minutes with the allotted time, so we can accept 1 or 2 questions and comments from the audience. Yes, please. Yes.
Yeah. I have 2 questions. The first question for Hiroko. What is your experience when you work with the nurses and physiotherapists? Because in Vietnam, we had many difficulty to work with the nurses in the ICU. I'm working with the nurses in adult ICU. People so busy with different things, and the physiotherapists have no support. add on, especially when the patient have hypoxemia. The second question is for Dr. Sun. The FFNC is used commonly during the COVID-19 period. I have opportunity to work at the Bưu Hai Hospital. So I see the problem between the doctor and physiotherapist, how to do exercise for the patient with breathing. And the patient should close the mouth and breathe by the nose. And I see it's difficult for the patient. How is your opinion?
Thank you for question. And I know the nurses, a lot of things in the ICU, so busy, and the doctor is busy. I know. So I think the communication is most important. Tell the truth that ICU have a already protocol, but no, you can't effectively use just only a lie down. Lie down is just lie down is just a paper, no me. So if you use make a protocol, but can effective to use needed most important needed is the communication with the medical staff. So not thinking difficult, just only a hello, how are you? Like this is okay, and I want to do like this. But if you have a time, please join us like this. Small thing is small step is a continued is a maybe a ICU is a more easy working together, and maybe a lot of ICU doctor and nurses want to more improve the patient is getting better. So I thinking is a communication. How you thinking? How do you think? What do you want to say? Is important. Just thinking is thinking. So to say and to communicate, maybe a lot of members want to working together like that for improve the patient. So communication.
I want to add more the culture in Vietnam. I'm working in the ICU in Chợ Rẫy, and I see all the staff, including the doctor and the nurses, are waiting for the physiotherapy come to help. So the doctor and the nurses are really respect the expertise of the physiotherapists. But we also see there one nurse had to take care for multiple patients in the ICU. So the number of the nurses over the number of patients, higher number of patients. So they too busy. So they have no time to speak to the physiotherapist or support the physiotherapy. Please don't think that the nurse doesn't want to collaborate with you in taking care of patient while you do the physiotherapy. In my presentation, during we talk about the importance of closing the mouth. SFNC improves the oxygenation of the patient because it generates beep with a beep of 6 centimeters quarter. Is only maintained when the patient closes the mouth. But if they open the mouth, the air comes out. So it's not achievable the beep of 5 or 6 centimeters. Normally the patient just open the mouth because the high flows. So we can use oxygen mask to cover their face. So the patient still open the mouth, but the mask still keeps the air around the face. So if the patient, he or she, impossible to close the mouth, so we use oxygen mask to put on the face, and we can keep we can maintain the breath. So it's important to close the mouth when we ask the patient to do breathing exercise. But we should support the patient.
Okay. Thank you for the speakers of this session, and thank you for the active discussion from the audience. So we will have 30 minutes of a tea break. So next session will be started at 3 p.m. Thank you so much. Preparing some.
So take it off so he can. Not the other one.
Yeah.
I'm not the first one. Somebody else.
Yeah.
We'll get started in just a minute.
Okay, this is the last session of today's Symposium A, the approach in ICU rehabilitation for sepsis and ARDS. I will introduce the next speaker, Mohammed Alif. He is from Hamad Medical Corporation. Mr. Mohammed Alif joined the Hamad Medical Corporation in 2007. And since then, he has been working as a PT specialist in areas of the critical care and cardiopulmonary rehabilitation. Before joining Hamad Medical Corporation, he was working as a physiotherapist in SCT MST, which is one of the national tertiary hospitals in India. He has more than 22 years of experience in the field of acute care physiotherapy and rehabilitation. And his extensive experience in an early mobilization of ICU patient and rehabilitation on ECMO and rehabilitation of lung transplantation. Today's topic is an ambulation of adult ECMO patient. Please welcome Mr. Mohammed Alif.
Yeah. Good afternoon, everyone. Thank you. Good afternoon, everyone. Thank you, Mr. Chi, for a great introduction. I'm Mohammed Ali.